Dr. Michael Maniaci of Mayo Clinic.
Thank you. I'm here to talk about Advanced Care at Home, which is Mayo Clinic's virtual hospital program. So when you think of home, there's a lot of things that you think of: freedom, but really it's control. Patients have control in their home. That's why we like our home. What happens when you get ill? When you get ill, you have to come to a hospital. Why? Because that's where the medical expertise is. That's where the care is. You give up that control in order to get that type of care. It's a trade-off. But my question is, why does there have to be a trade-off? Could we break that scale? Could we deliver that medical expertise where the patient feels controlled the most, in the home setting? And that's really the core concept behind this. We started with the patient. We talked about hospital at home, advanced care at home, delivering that care in that setting. Think about other reasons why we want to keep people out of hospitals. First of all, unintended consequences. 1 out of 5 patients gets delirious in the hospital, has things like falls, mobility's decreased because you spend 90% of your day in bed. You catch infections. 100,000 medical errors a year cause deaths in hospitals. We try to make them safe. We try to do our best, but they're not the safest place to receive care. Capacity is an issue. We see that hospitals run at 95, 97% just to make a margin. What happens when we're stressed, like in a time of pandemic? We run out of beds for people. People can't get the care they need. And then finally, cost of care. Average 3-day stay in a hospital, paying out of pocket $30,000 for somebody who's acutely ill. 2 out of 3 bankruptcies filed nowadays in America is because of medical bills. We're literally breaking people because of the cost of care. Could we address these at the same time that we give patients control? That's the question that we look at. So why don't we just treat everybody at home and try to avoid some of these things? Well, I'm a hospitalist. I treat 15, 20 patients a day at a hospital because they're right there. It's easy. I have several nurses that can see those folks. How many people could I see if I traveled around Jacksonville? 4 or 5? Am I going to put a nurse at each person's home in their bedside? It's not possible until now with technology to help enable it. And there's 2 words that do that: virtual hybrid. Take the high-cost care, the physician, the bedside nurse, the medical decision-making, make that virtual, and use lower cost but high efficiency in-home services to deliver the care that we come up with. And that's the way you do it. I'll show you how it works. First of all, we don't want to make the patient's home into a hospital, but we have to collect data. So we install technology into that home to collect biometric data and to communicate with the patient. Next, we have a command center. Ours is here in Jacksonville. Software collects all that data, delivers it to us and our care team. In that command center, it looks like a hospital ward. A physician, a nurse, pharmacy. We make decisions there, and then we implement that care through a supply chain that we build in the community and delivers that care to the patient. Whatever decision it comes from me, but I'm not the person pushing that med or doing that. That's the supply chain delivering that care. That way we're able to deliver care wherever we build the supply chain, and we'll show you where that is in a minute. This develops a lot of capabilities for our program. One is you can use the system for a lot of different types of care: post-medical care, post-surgical care, post-procedural care, transplant. Anywhere you can build a supply chain and have the care plans built, we can institute that care, and you can do that across state lines or across the country. Next, it develops a different payment model. We can start to work with payers to develop a process of paying for quality of care and keeping people healthy in their homes, as opposed to the high cost of hospital bills. And finally, and we've seen this somewhat in the pandemic, is we can start breaking down some of the regulatory barriers of practicing across state lines or in different countries. With virtual care, you can practice almost anywhere, but we have to build a regulatory system to provide that care. People enter our hospital at home 2 different ways. One is directly from the ED. They come in, they're ill, but they're clinically stable. I move them right out of the ED. Instead of moving upstairs, I just move them to their home. Paramedics take them there. We institute the care. We start treating for them right away. Other people need the hospital. They need a surgery or advanced procedure, or they're clinically unstable and have to go to the ICU. Once they're stabilized, instead of spending 5, 6 days in the hospital, 24, 48 hours, I can then move them home and start treating them there. In the future, I hope to have a system where you don't even have to come to the hospital. You get sick at home, I can activate a system, diagnose what's going on, make a decision if you have to come to the hospital or not, and then treat you right there in your home setting. We own these people when they're at their sickest, but we also have the opportunity to own them past the hospital stay, take care of them for 10, 12, 30 days up to, in order to make sure they get the education and care they need so they don't come back to the hospital again. We use this type of technology. Right now, it's a lot of wearables, collecting biometric data. In the future, we'll have more camera technology, Wi-Fi technology, where people won't have to wear anything. We can just monitor them and get that data. We have redundancy in the home. It's not just the iPad, but it's a Wi-Fi phone, it's a cell phone, it's a life call system, it's a backup power supply for 3 days worth of power, it's a backup cellular system. Connectivity is key, so you never lose sight of what your patient is doing. Building the supply chain is tough. There's no less than 18 modalities you have to build in order to implement care in the home setting. Some are straightforward, pharmacy, laboratory, other things like medical waste, medical meals, security. This is not all owned by Mayo Clinic. These are resources in the community that we can build together this workforce and implement and share in order to institute this care in the home. Finally, the command center. The command center is here, Jacksonville, Florida, on our Mayo campus, but it just does not take care of Jacksonville patients. We can take care of patients wherever there's a supply chain. So we have supply chains in Phoenix, Arizona, in Minnesota, in Wisconsin. Any particular day, I'm taking care of different patients across 4 different states, 3 different time zones, 1 physician, and a couple bedside nurses. That's the power of this system. I could take care of patients here, Phoenix, and France all on the same day if I wanted to with 1 physician. So we can share our knowledge throughout the world without having to leave the backyard, which is very nice. As of this week, we've actually taken care of over 1,000 patients in our system over the last 2 years. These are hospital-level patients, a severity of illness of 2.8, truly ill people, not glorified home health care. And then finally, patient experience is quite high with our system, over 90%. Why is that? Here's a chart. On the left is a typical hospital stay. On the right is a hospital at home, advanced care at home. What happens, when does your physician show up in the hospital? Usually when you're in the bathroom or you're eating, you're asleep, or your family's away. Not here. Everything's scheduled. So you can have your family there. You can video people in. You know when you're going to talk to me and when I'm going to talk to you. You have free time, too. I encourage you, visit with children, go outside, sit on your porch, take a walk if it's okay. Mobility is important. Social interaction is important for wellness. I've never had anybody complain about using their own shower at home as opposed to getting a sponge bath in the hospital. It just doesn't happen. You have the conveniences of home, your own bathroom, your own bed. That really works out. And responsiveness, as I said before, is key. So you push a button, you're talking to one of our virtual nurses within 30 seconds, as opposed to the hospital now, where if it's not an urgent issue, it's a bunch of pager phone tag. She can take it up to an hour to answer an issue, simply like getting up and going to the bathroom in the hospital. So again, responsiveness is great. Finally, what does this do besides that excellent patient experience? A couple things. First of all, you saw the pretty pictures that they had up here of all those $1-million buildings they're building, all those hospital beds. I mean, the average hospital bed costs $2.5 million per bed. So you're building, 100 beds, you're spending $250 to $500 million. What if we didn't have to build all those buildings? We still need them for our sickest patients, but what if we opened up within, a few days as opposed to a few years, all these virtual beds where we can take care of these high acuity patients, save the beds we have for the people that need the surgical care, the ICU care, the truly hospital level care. Next, this is some of the best medicine I've engaged in, because when people are with me in the hospital, I'm towering over them, I'm in control. We flip that on the script. Now I'm a guest in their home. They have to partner with me with their medical care. They engage in their medical care. They get better faster. They follow my directions. They want to get better. It really works out well for the patient. And then finally, the cost of care. 50% of what we charge patients on all these bills is really allocated costs. The cost of those pretty buildings, the cost of cleaning the floor, sterilizing, all these other things. What if we could cut down those costs by not having to build all this stuff or clean the rooms as many times because we don't have them, and pass that on to the payers, the patients, and drive down the cost of healthcare? That's really what we're going for as well. So really, if we build the system right, everybody wins. And I'll end with that.